the night and need a recording to watch. So if you know anyone that fits that bill, this session, the first session of the series, and the final session next month will be on YouTube to watch. You can do a mixed method of sorts if you need to watch the first session. And then for those 3 CEUs that will be available after next month's session. So if you can see behind me, I have some really fancy curtains. I'm coming to you from the American Society of Criminology Conference this week in Chicago. So I'm here in Chicago. Just in case I lose connection, hotel Wi-Fi, we'll see. In case I lose connection, just if you'll try jumping back on the Zoom meet, we'll try to get us back up and running. But yeah, so you see a list here on the screen. Take a moment, look at the list, and which items do you think indicate that a client is at high risk of recidivism? And recall, when I'm saying recidivism, I just mean a client who is likely to continue engaging in criminal behavior. So you can come on your microphone, you can chat, let me know if you have any initial thoughts there. We'll also kind of come back to this about midway through the presentation. All right, so hopefully you've had a chance to look over that list and just start to think about what criminogenic need feels like to you, what it's meant to you thus far in your work. So let me switch slides here, there we go. If you'll just take a minute and add your name, your program, agency you're coming from or affiliation, and the email address that you would like, I'll just make sure to send you the link to the CEUs, the YouTube. Afterwards, I'll make sure that you have access to the slides. Thank you for being here. Go ahead, and if you want to send that to me privately, you can always make that selection in the Zoom chat by sending your information directly to me.
Hey, that Jonathan Twitch just called. Did you have
You see my email address there. I'm a senior research analyst with the Utah Criminal Justice Center. If you have any questions for me, you can always reach out. The Utah Division of Substance Abuse and Mental Health also, they offer technical assistance for Utah's treatment providers around these concepts. So if you want specific technical assistance for yourself, your staff, your agency, please reach out and let me know what that looks like to you. And we'll see how the Utah Criminal Justice Center can be of support to your efforts in serving justice-involved clients. That's really our goal here tonight. So as I said, here we are at the skills series, Risk-Need-Responsivity, RNR model for working with justice-involved clients. This is really geared to be an introductory model, really orienting you to these concepts. I hope each of you walk away with something new to think about this evening. If you have any questions you came with, please put them in the chat, or go ahead and I'll kind of be quiet for a moment so you can just jump on the mic and let me know what those questions are. If you have any questions because you're at the first session and you've been thinking about that, let me know.
Hold on, I just need to turn off my video for a second.
To those adding contact info in the chat, I'll be sure to stay in touch with those materials.
Hey, can you hear me? You're going to hear some talking in the background, but hold on.
All right, so we have our website. You're welcome to take a look at our ongoing work. It's ucjc.utah.edu. We do a number of kind of interdisciplinary projects. The one that we're focused on here is supporting community treatment providers in your work for in serving justice-involved clients. So that's what we're focused on. I'm coming from the perspective of really being involved in a lot of program evaluations. I've completed program evaluations using this tool, the Correctional Program Checklist, that comes out of the University of Cincinnati Corrections Institute. And it really is a tool to kind of help programs understand where are the practices and efforts looking at in comparison with the research, what we know works. You can see Ed Latessa's name. You may be familiar with Ed Latessa's work, Ed Latessa's colleagues' work. It's a valuable tool. If you want to know any more information, this is kind of the cover sheet. I can send that over. So really important to kind of gear ourselves toward focus here. I respect that as community treatment providers, you don't have one focus. You all have many tasks at hand in order to properly attend to the needs of your clients. Here, we're going to focus, dial in on that justice involvement piece. So recidivism, as measured by criminal acts that resulted in rearrest, reconviction, and return to prison with or without a new sentence during a 3-year period following their release. And today we're going to just focus on what decreases the likelihood the individual will engage in future criminal behaviors. If you just want to take a look at the session 2 learning objectives, let me know again if you have any special, particular questions or reasons and things you want to try to work on with the group here tonight. There's 15 of us here. I'm so happy to see that. So plenty of voices to kind of lend an ear and some support on questions you may have about your own program. I hope that, let's see, we'll have a case studies coming out here at the end of our session, the second half of the session. So if anyone needs those, or would prefer those pulled up as a PDF instead of looking at the screen for the PowerPoint slide, let me know and we'll kind of take a break before we move into those, and I'll work on sending those out by email. All right. Now, I just want to do a quick review from session 1, make sure folks are feeling comfortable with that risk component. Here's what we covered in the first session. Of course, there's a recording on YouTube if you'd rather watch the session. We really wanted to differentiate between the risk of recidivism with justice-involved clients and the risk of relapse, relapse speaking to substance use, the concept of probability of the risk of recidivism, and the evolution of those criminogenic risk assessments instruments that you may have come across, the LSR, RNR series. Maybe some of you are using the LSIR screening version at this point with the division's support. So what is criminogenic risk? I just want to drive home a few points before we move forward. Not every justice-involved person poses the same risk to the community. So what is risk? Risk is not danger. It's not seriousness. It's not blameworthiness. Risk really is chance, probability, and we have to keep in mind that high risk does not mean that these individuals are 100% likely to recidivate. There's a fair amount of misconception on that. You can kind of think of weather or different areas where risk shows up in your life where you're thinking, where it's kind of easy to slip into the mindset that it will happen, when really it's just the potential that it may happen. So it's actually around 50 to 60%. And it just means that someone who's high risk assessed on an instrument has a higher probability that they'll recidivate or commit new crimes than someone who is moderate to low. And on the flip side, low risk doesn't mean that they will never recidivate. It just means that their probability is far lower. So let me just make sure I'm noting the points that we covered last time. Risk of reoffending is not the same as offensive severity. That's really important to note, and that's why those instruments are very important. An individual who's committed murder may be at low risk of reoffending despite the seriousness of the crime, and similarly, an individual who has committed multiple misdemeanors but no serious crimes may have a high likelihood of reoffending. So that's where these instruments really can be beneficial to give you a bigger picture of your clients. In this audience, it's really important to cover relapse and recidivism. And while substance abuse is an important criminogenic need that we're going to come and speak about throughout the session, treatment for substance use disorder will not on its own reduce the risk of recidivism. So this is because moderate and high risk individuals, by definition, have multiple criminogenic needs. All right. So why is criminogenic risk important? The risk level is telling you how much treatment an individual will need to reduce the likelihood that they will engage in ongoing criminal behavior. It's also telling you which clients can be combined in treatment groups. So low risk clients, you may have heard this through the division recommendations for separating low and high risk. It's really important. There's a a fair amount of research supporting separation due to the risk that those low-risk clients can be negatively impacted, not only by removing them from the pro-social things in their life, work, family, community, by giving them too much dosage or treating them as high risk or moderate risk, but also exposing them to folks who are high risk, may increase their risk over time. All right. So tonight we're really going to be, you can see that that fourth generation is bolded. When we look at risk assessments like the RNR, that's really looking at this fourth generation where risk assessments went from being professional judgment to actuarial risk scales, and then began looking at risk need scales. And now here we are in the fourth generation where there's an integration of case management with the risk need assessment. This is really, this is important for treatment providers because you want that case management piece. You want these tools and instruments to work for you. You want them to help guide treatment and be really a useful, if your staff is taking the time to deliver and administrate these instruments, the tools should be working for you and helping guide treatment. So I hope you're finding that we can touch base on that as well. So last time we were really looking at risk, who to target. Hi, Kathy. Thanks for adding your name to the chat. If anyone's come on and they've just joined, just go ahead and add your contact information, either sending that to me directly or adding it to the chat just so I can make sure to keep you in the loop on the link to the CEU quiz and evaluation. Sorry to switch gears there. So last session, we really looked at who to target, really encouraging and supporting a targeting of moderate to high risk assessed justice involved clients in your services and the services you're delivering. Tonight, we're really going to talk about what to target, really orient folks to the criminogenic needs and offer some intermediate treatment targets so that you can start to think with your teams, what does this look like when we add it to the treatment plan? Now, again, this session is geared towards an introduction to criminogenic need. My hope is that you feel like I need to know more. I need to know more. So please reach out after this session if that's the case, and I'll work on hooking you up with the right resources for you and your team. All right, so let's come back to this test your knowledge. And let's see familiarity, if that's all right. So when looking at the following list, which items, if you don't mind kind of engaging as you're able from where you're zooming in tonight, which items do you think indicate that a client is at high risk for recidivism? Thank you. Low motivation to change was listed in the chat. Just make sure everybody has the same kind of familiarity with Zoom. If this is your first time logging on, you'll have a bar at either the top or the bottom. And if you hover over that, you can choose the chat function. So we had one person say, low motivation to change, lacks empathy, young age, criminal contact. So maybe a history of criminal contact, homelessness. Thanks for these suggestions. So just to start kind of talking about it, many common treatment targets, such as motivation to change, studies have found that they do not actually reduce the likelihood that a client will recidivate, but treatment intended to reduce the risk of recidivism should prioritize, homelessness and motivation to change as responsivity. So let's talk about that at the third session on responsivity. So really asking you to target those things that are shown to us be associated with reduced risk of offending. And then also whilst considering being mindful of, I want to reduce the risk of recidivism, I have to pay attention to homelessness. I have to pay attention to motivation as responsivity factors that are keeping my intervention from being a successful way to reduce their recidivism. Homelessness mandated to treatment. All right. I'm just going to flip side here. So this is sort of how we parse those out. You can start to see on that left-hand column the criminogenic needs that we will talk about this evening. And on the right-hand side, it's not to lessen or diminish these right-hand side factors that will play a role in your client's success, but to sort of think of them as responsivity factors when we're using this risk-need-responsivity RNR model. Okay, so let's shift gears. Just want to check in really quick. Anybody have any questions before we dig into criminogenic needs? So criminogenic needs are crime-producing problems, which is to say that those areas in an individual's life be addressed through the treatment in order to reduce the likelihood that the person will engage in future criminal behavior. These are the things that we have control as treatment providers. There's some movement. There's a possibility of lowering the risk in these areas where criminal history you cannot change. So this is where the potential is. And these needs often work in tandem with each other. So, this is going to present them as very clean cut. And I'm sure all of you know good and well that they cross over, that they connect with each other, and they reinforce each other. So it's really kind of gathering where those needs are, prioritizing those that are demonstrating as high at that point in the client's assessment, but also considering where those moderate and low risk factors play a role for that person. And we'll get into that with our case studies. So wanting to really encourage you all to take the Division of Substance Abuse and Mental Health up on using the LSIR screening version at the minimum, orienting yourself to these validated assessments that have been shown to be reliable. Across the studies are large enough that they've been validated in multiple populations, and you can rely on them to be giving you good information about the client that's in front of you. There are also other instruments to choose from. However, though, you want to make sure that they've been validated for the population you are serving. All right. Oops, sorry about that. So this is a huge list here. It's a full slide, but here are the criminogenic factors. I'm just going to give you all a quick moment to just briefly read through those. Of course, access to these slides is available. All right, so when we're looking at antisocial behaviors, this client may routinely have their needs met or resolve their problems through means that are illegal or indifferent to the well-being of others. That's antisocial behaviors. Antisocial attitudes. So these are the views that are supportive of a criminal lifestyle, such as negative expressions of the law, conventional institutions, self-management of behavior, a lack of empathy and sensitivity toward others. You might hear clients saying things like, it was really her fault for leaving the purse on the chair. So that's what we're talking about when we're saying antisocial attitudes. Anybody have any examples from, of course, de-identified and respectful of privacy, but any examples you wanted to add to the chat of language descriptors for antisocial behaviors or antisocial attitudes that you see in your treatment will likely be helpful for the other folks that are on the call, just to see how these are manifesting in treatment, rubber meets the road situations. All right, please feel free to add those to the chat if they come to mind. Antisocial personality patterns. So many high-risk individuals are self-centered and may have an inflated sense of self, and this is in contrast to the commonly held perception that people who commit crimes suffer from low self-esteem. So criminally involved individuals are more likely to be negative or hostile in interpersonal relationships and lacking in self-control. We had an example come through the chat that says, minimizing my role for why I got arrested, thus minimizing my responsibility for it. That's a good example, and it's going to come up again in our case study. So awareness around responsibility for that moment where there was justice involvement. Kind of continuing on down the list, antisocial peers. This comes up a fair bit. Clients who have a problem in this area will have primary relationships and friendships that model, reward, and reinforce criminal values and behaviors. They may also lack relationships where such behaviors and values are sanctioned. Anyone have experience with antisocial peers coming into the treatment targets and plans? We had another example come into the chat, feeling that they are a victim of the system, mistrust in the system, the society owes them, etc. So y'all as treatment providers really looking to move towards accountability and kind of a recognition of their place. It's not to say that there aren't occasions where folks are victimized by larger institutions. However, when you're working with someone and trying to reduce that criminal, the risk of recidivism, really, where is that place of accountability? Is there anything? Is there a source where that accountability can be accessed and take a part in their treatment plan? So let's see, family relationships, family marital relationships. So for juveniles, this may include low levels of parental affection or supervision, but for adults, this is going to include family relationships that model and reward criminal attitudes, values, and behavior. So this can sound like I get into trouble when I'm around my dad. I really love my family, but they aren't that good for me. So there's a slight bit of awareness between those two statements. You can hear, a little bit of awareness of that relationship, probably varying levels of awareness of relationships, across treatment for one individual that you all serve, or across the, one group session, maybe different levels of awareness of both peer and family influence. All right, so also, educational or vocational achievement, low levels. This includes problems in school, lack of stability in job history, and a history of conflict in school and work. It can also be a client who does not see the value in school or work and instead prefers to support themselves through criminal activity because it's easier, more lucrative. Being in school or at work can structure time, increase exposure to positive relationships and activities. However, to succeed in these settings, clients may need help developing those skills involved with employment. So their attitudes about work, self-control, problem solving, getting along with coworkers. And just with that last example, you can start to hear, getting along with coworkers, pro-social peers, anti-social peers. We already can start to see the connection between these criminogenic needs and how that will show up in various ways in this individual's life. All right, so leisure activities. We actually have Chad Shubin from Wasatch County Family Clinic did an event with us earlier in this summer on leisure activities. And that may come up for you all a lot, where the client has a limited involvement in pro-social leisure activities. The client doesn't have habits, relationships, or social networks that promote pro-social activities during unstructured time. They may have a lot of unstructured free time, and they may express concern that they don't trust themselves to stay out of trouble when not engaged in structured activities like work or treatment. So this is really interesting. You're seeing folks that might be very isolated, maybe especially during the COVID-19 pandemic. You also may see folks that are a little bit into treatment, and you see them packing their schedule, just working multiple jobs, going to treatment, really working hard. And you want to say, oh, that seems really positive, but is that sustainable for them when they feel like they can't stay out of trouble? Is there anything around that they feel they don't know how to manage that leisure time, that time we all need to recover, to connect, to build parts of ourselves that aren't only focused on treatment activities, reporting to probation officer, doing the required things that they may be that needing to do while they're in treatment. Okay, I'm gonna walk through this substance abuse. You all are likely familiar if you're here at the session, but abuse of alcohol and drugs that can lead to interaction with antisocial peers. Again, with the kind of a connection to a different criminogenic need, it can impact their social skills, their decision-making. So getting back into those earlier social attitudes and beliefs, decision-making. And it might also be illegal on its own, which in Utah, we know that drugs, there's a fair amount of illegal drugs that clients may be utilizing. So there's the list. Anybody have any examples they want to share or kind of questions that are coming out? some of you may have a question, I see criminogenic risk factors, Jessica, like why is there criminogenic needs? Why are there criminogenic risk factors? Criminogenic risk factors, we're talking about what the studies are showing reduces overall risk of recidivism. And then you look at criminogenic needs as those dynamic risk factors that we can change. Does that language kind of sit okay with folks? Seeing some stuff coming through the chat. Lack of parental moral training and little or no knowledge or belief in God and an eternal post-mortal perspective. Thanks for sharing that. When using, they can also show lack of empathy and paranoia. Thanks for contributing that. Appreciate that. So scaffolding, I mean, I'm sure you all have experience with just, what are these? We're going to get into the intermediate treatment targets, but, for newer clinicians that are just kind of coming into this model, a lot of questions that come to mind are, what are the incremental steps, treatment targets that I need to do to build lack of, if they didn't have that moral training, rules, understanding of things, understanding of what it means to show up to a job, what are the expectations there? So there's a lot of scaffolding in terms of treatment intervention. Sometimes a lot of skill-based, which in responsivity, which is the final session of the series, we're going to talk about responsivity, which general responsivity is looking at really skills-based CBT. That's where CBT is going to come in, cognitive behavioral interventions, where we're really demonstrating, modeling, practicing, getting folks ready to live a new life. Okay, thanks for the chat. So let's move into these intermediate treatment targets. So the whole treatment team should be familiar with the client's risk level, their criminogenic need areas, and their treatment targets. So that's peer support specialists, case managers, leadership, the clinicians, who else, probation, the whole team ideally is really going to be aware and staffing on the risk level reductions with reassessment and criminogenic need areas that you're targeting. What I've, 2 to 3 targets at one time. Once you get that assessment back, really selecting with your client. I'm seeing this on your risk assessment, on the say the LS-RNR or the criminogenic need assessment. I'm seeing these as high risk. What does that feel like to you? Is that feeling like the issues that you'd like to target in treatment, and only tackling 2 to 3? You don't want to be taking on too much. So we've kind of went through who interns, if you have any interns at the practice, they should be aware of this as well, the risk level, the need areas that are being targeted, so that when they're facilitating the DBT group for their internship, they're aware that, Jessica is really working on pro-social, antisocial peers, building pro-social relationships. That's my highest need. That drives my substance use. So that's a really big, if they hear me saying anything during DBT group that night, that they can reward and incentivize me. Jessica, that's great that you went to the grocery store and you talked with that person when you asked for your order at the deli counter. Way to go. That's big for you. That's awesome. So, all right. So let me just pull this chat over a little bit. Sorry. So let's read through these intermediate treatment targets and see if folks have ways that they are targeting criminogenic needs that they want to share with the group. Please do. I'll make some space if you want to come on the microphone, but also the chat's available. So antisocial behaviors, teaching and practicing skills for resolving problems and meeting needs in non-criminal ways, recognizing thinking patterns that justify criminal behavior, and challenging thinking that supports criminal identity. Antisocial personality pattern, you may develop and practice skills for problem solving, self-management, and communication. Antisocial peers, you want to teach and practice refusal skills, use group work to practice challenging antisocial thinking amongst peers. Family marital problems, reducing conflict, enhancing the family's ability to monitor and reinforce behaviors and attitudes. You're seeing a lot of practice on that list. Anybody have any questions or things they'd like to add that they've seen on their own treatment plans at their practice? So again, hoping that your whole team is aware of, of client, you have contact with the client, that you're aware of the criminogenic needs that are important to the clients, so that you can positively reinforce pro-social choices and pro-social associates per se. And then you can use consequences to address behavior. Say you're using the moral recognition therapy, MRT intervention at your practice. Does that person have antisocial thinking as one of their higher risk, needs? Is that why they're in your group? Or are they in that group because they're justice involved? So you can start to refine who's in your MRT group, making sure that it's useful for them, that you're targeting, in their individual treatment session, we're looking at their antisocial thinking. So MRT is a really great fit for them right now because it's going to amplify that. And then the group facilitator is going to reinforce the work I'm doing individually by saying, wow, that thinking pattern was different than you were doing, last session. Or, that was a general example. Anyone have like a more specific example of, a positive reinforcement there? You thought through that in a new way to take accountability for that thing that happened this week. So you see how they, group is supporting individual in targeting an assessed criminogenic need, not taking on too many needs at one time. Now, here is where you all can appropriately say, Jessica, the rubber meets the road. I'm going to get all my clients into this situation. Or does this feel possible? Is it possible in staff meeting to say, we're looking at 5 to, or, how many people are in your group session? So maybe 10 people. How can we say, Jessica's targeting this. This is really important for Jessica this week in terms of targeting her criminogenic need. This is really what I'm working on with Emily. This is, and focusing in so that the facilitator goes in knowing what they should amplify, what they should support, what they should be mindful of, so that they're not reinforcing behaviors that are going to promote future recidivism. Because ultimately it benefits the client if their criminal risk reduces by the time they finish your program. They're at low risk. They can enter different groups within your practice because they're not sort of bringing the higher risk mentality into that group and changing putting others at risk. You can bring them into different groups more safely. And also, reducing their risk of recidivism means they stay in the community, they stay with their family, they stay in their job. So that's why this is important. Okay, let me shift gears here. So we have 3 remaining. These, some of you may have some familiarity with RNR, and you may have heard, the top 4 and then the other 4. Recently, that's not the case. We aren't looking at the top 4 where it was at his last slide, the first 4 and then the remainder. We now know they just all work so dynamically. There's not a top 4. These are the treatment targets. These are the criminogenic needs that have shown to reduce recidivism in justice-involved clients. So school and work really, you see these skills coming through, developing problem-solving skills, increasing motivation and opportunity for employment and education, identifying interests and opportunities. It's important for you to have a leisure activities. It's important for you to have a break. What will that look like for you after treatment? I know right now you're juggling work, you're juggling treatment, you're juggling probation check-ins. How are we going to get you into the framework where you slowly start to bring leisure in so that in those quiet moments, it feels rejuvenating and you've developed new hobbies that are going to bring you joy or relaxation, not make you fearful because now you're alone and you haven't thought about what that time's going to look like yet. So Chad offered a really great example of planning a trip, just the benefit of planning a vacation, just the exercise of thinking forward. What will that look like? You can start to practice some skills around, who comes on that trip? How am I going to pay for that trip? How will I start to engage with some of the skills I'm learning in group or in individual sessions that I'm, cross other criminogenic needs? And substance use here is our final intermediary treatment target, reducing personal and interpersonal supports for substance abuse, teach and practice relapse prevention skills. Okay. All right, so we're turning back to the list here before we move into the case studies. I'm just going to leave this up. I may not have asked this in the best way, but will you just let me know one more time in the chat if you need me to get the case studies to you directly as a PDF because you prefer that to reading it off of the slide? Let me know. I'm going to take a quick drink. Okay. Okay. Your Zoom name, will you let me know the best email address to send that PDF to? I don't have a kind of a first name with your Zoom login. Thanks for folks' patience while we make sure everyone can sort of digest the case studies in a way that's helpful for them. Going to everyone that would like it. In an in-person session, this would be where I'm passing the handouts out. So, you're stretching, grabbing a drink, connecting with each other. Okay. So Rachel, thanks so much for your email. I am passing that over. It should come to your email inbox shortly. And everybody, here we go. So these case studies, thank you to the Utah Department of Corrections for supporting our ongoing partnership with public and private treatment providers through the Division of Substance Abuse and Mental Health. That was a lot of words. These case studies have been revised a little bit by myself and my teammates for training purposes. Of course, the names we use are not real client names. They've been de-identified and they're really used for training purposes, but these are real clients, really trying to get you guys some examples that feel more tangible and real to you. Okay, so last session we used this case study, this first case study, Jake, and I'll give you a chance to read over it. And then I'm seeing a few more folks that want the PDF, so those will be sent to you shortly. Okay, Chris and Angela, those are heading your way. The goal here really is just to start to familiarize yourself of what the criminogenic needs, the dynamic needs you're going to be targeting in treatment look like when you hear someone's story, starting to pull those out. Right. So before I share, what those criminogenic needs that were assessed on the LS-RNR, what those were, anybody have any ideas they want to share? What are the top top needs that Jake has when building his treatment plan. What do you want to target right off of the bat? All right, so I'm going to go ahead and share. Jake's probation agent reported that he scored high risk to reoffend in criminal history, family marital, leisure and recreation, companions, and pro-criminal attitudes. So returning to my earlier point, you can see that it's not one need, it's many that are creating a high risk assessment. So when the LSIR screening version comes your way and says high risk, this is why Jake it has high risk of recidivism. His results show that he scored moderate risk in education and employment and antisocial pattern, and low in substance use. So this may not, okay, let me see. Tarius, thank you. For one thing, I'm gonna make sure I can control the chat here. Scrolling. For one thing, keeping away from people that are going to be corruptive influences. I would start with, Lincoln says I would start with thinking errors, working on bringing his all or nothing thinking to a more moderate level. Introduce positive social communities, activities, ties. Rachel, what in your community that you're coming from, what are some of the community activities and ties that you depend on? What are you pulling from in terms of your community resources that have been good examples for your clients or good, resources? I know with some of the groups, okay, AA activities, church, local activities in the community. During CPC site visits, we've heard gyms. Sometimes gyms will give free passes to have folks, here's a reward for showing up to group on time for a free gym pass. I know that that's changed during COVID, but one resource that came up. Any others from, fairs, fundraisers, softball? Anybody else pull from some great resources in their community that have really worked for their clients? Thank you so much for sharing those examples. He needs social support, sober social support as a base to launch better behavior as he learns. Okay. So Jake had just a final note, Jake had multiple criminogenic needs, high risk to reoffend in criminal history, which as we know is not dynamic. You can't change someone's history, family and marital, leisure, recreation, companions, and pro-criminal attitudes. Now, although there may be a dynamic interaction between those four, you might want to work with Jake and say, what are the top 2 or 3 that we can start with? Chris says sober social support. So what's going to happen with the relationship with the girlfriend? Is there any workability there in terms of building a life and additional activities outside of the relationship? Not in a prohibitive way, but in addition to joining softball alone, meeting some new companions. What groups do you all use that might be a good fit, for treatment groups for, changing those thought patterns? Getting involved together, okay. So thinking errors, thank you so much for that group suggestion. So I think Rachel, you bring up a good point. I'm working from a case study here. So, you know, you would be across from this person and really know Jake and the girlfriend's relationship better than I would, and able to know, you know, where is Jake at in terms of that relationship? Where's their motivation to change? And there's where we're going to come back to the responsivity in the next session. Yep, staying clean and sober could be synergistic to both of their future lives. Great. Thank you all. Okay. Any questions or sort of like flags coming up on this case study or the examples that were shared that you all want to talk about before we move on? Yeah. So this may be, you know, an interesting case study to work with first off the bat, because substance abuse came in as a low risk. You know, you all are probably like, if they're at my program, they're here for substance abuse or, you know, to treat the substance use diagnosis. So it might not be the best fit. That's why we have our second example coming in here, but just wanted to give you an example as we're talking about criminogenic needs, that sometimes there are larger needs to attend to for an individual in terms of their criminogenic need overall. So I hope that was kind of a helpful exercise. A lot of text. I'm paying attention to the chat. If you like want to change your mind and you want that PDF to come your way, I'll give you a chance to read through Lisa's case study here. To practice so I can play you all some music during these moments. Sorry, I'll build my skills. You all feel ready or, you know, want to, you can start adding to the chat. What are you seeing about Lisa? What's on your radar as treatment providers? What criminogenic needs are coming to your attention? Substance use. Thanks, Chad. How are relationships really amplifying, changing Lisa's relationships to substance use? I appreciate you all bearing with my love of the word amplify this evening. That happens, right? You pick a word and stick with it. Adverse childhood experiences, thinking about ACEs, driving criminal behavior, and drug use. How many of you are assessing for ACEs to practice at your agency? We do at mine. Thanks. Completing substance abuse treatment, individual strength building, boundaries, help with steady employment. Those are some of the criminogenic needs coming to Rachel's forefront, prioritization. There's a bit of a cycle here. The emotional instability promoting substance abuse, which promotes theft, criminal activity. Thank you. Thank you all for offering your thoughts and what you're pulling from this case study. I'm going to go ahead and share the risk assessment showed her as high risk to reoffend, substance use, companions, pro-criminal attitudes, and employment were the highest need areas in her life at this time. Her living situation may be impossible to stay sober at. She really needs sober friends, church, new moms group. What are some of the sober resources you all have that are running right now? Are things getting back online after the COVID pandemic? See sober activities like these in your communities that you could put in the chat and help other practitioners out in terms of sourcing resources. How can the treatment team help Lisa feel comfortable about her teeth, her appearance, her self-esteem, so that she's willing to go to the new moms group? Who's at the new moms group? Our AA and NA groups are back up and running, Rachel says. Okay, so suggesting referrals to help with dental and medical help. Great integration of different teams, different components of the team. Some of you, I mean, I know Odyssey House has some primary care resources there within the agency. Some of you may be pulling from other community supports to help access those specialists or medical dental professionals. Overeaters Anonymous also supports eating disorders. Great suggestion. Thank you, Lincoln. You know, there may be online options as well, still virtual groups running for these groups. Okay. Okay, so Chris, you're describing, if I may, and correct me if I'm wrong, sort of looking at leisure activities by using personality type tests. So targeting activities and work for her personality. So that also looks at education, employment, leisure activities that she would find fun, enjoyable, diverting. Thank you so much. Lincoln offered a link to donateddental.org. Great, thank you for the resource. If anyone, isn't close by a pen or a Word document that's open and you want the chat, you want access to some of this great feedback that folks are providing, I'm happy to get that to you after this session. Just reach out to me at my email address, which I'll give to you again before we finish up. Okay, so the great thing about Lisa is we have a second part of the case study. So I'm going to just flip the slide here. I should have given you more warning before that flip. I hope I didn't jar anyone. But here's part 2 of Lisa's case study. Reassessment. So really reinforcing this idea that it's not a criminogenic risk and need assessment is not static. It's a dynamic tool to help you across the treatment length, and in understanding if Lisa her treatment targets are being met successfully, her risk is lowering. Spoiler alert with that. We don't know it's lowering yet. Okay, so here we can see some progression. We see some great work after a year of treatment and probation for Lisa. We also see some remaining criminogenic needs. So pulling out where you're seeing criminogenic needs, pulling out successes. Right, give you all a chance to put some, what criminogenic needs still feel important. Family therapy with parents could help them see her with more compassion and help guide them, not to rescue, but not reject her. She needs to get involved in new social hobbies. This will fill her alone hours and loneliness. Nature abhors a vacuum. I really like that. Thank you. So she could fall back into old habits if she doesn't replace them with new ones. Thank you. So reassessment showed Lisa at moderate level risk to reoffend. This is a reduction in risk from her assessment a year before. I might be having some instability with my internet. I'm hoping you all can hear me okay. I think it's okay now. The areas of highest need for her in this assessment were companions. So you all have noticed that. Pro-criminal attitudes. And the results show leisure time, substance use, and employment as moderate areas. And as we sort of start to think about the final session in this series, her trauma history, housing, and transportation continue to be barriers for her to reduce her risk of recidivism. That's important. Parenting, support, and education. So y'all are seeing, both relationships with her parents, relationships with her children. Okay, I'm going to go ahead and change the slide. Heads up. You all have access to the PDFs of these slides. If you don't, let me know. Here is kind of just this, here's where we are. December 16th, 2021 is our final session. If you can join live, please do. It's great to have you. If you can't, we'll make sure to post a recording of the session so you'll have access to 1, 2, 3. If you feel like this would be a good introductory session to an intern, to new staff, to someone who hasn't worked with justice involved clients and says, what do you mean by RNR? What are you talking about? What is this acronym? Please, use this resource. I hope that it gives them a good introduction. And that's all it is. It's an introduction. So we're here for you. My email is jessica.seawright@utah.edu. Let me put that in the chat. If I see a question come through, I'll answer that in just 1 second. Here's my email address. We're here for you to provide any kind of deeper technical assistance. If you have questions about the training or strong feelings about, what we could have done, please add that to our kind of like the evaluation quiz when you get a chance, or let me know. We really want these to be useful trainings that offer a lens into risk, need, and responsivity for serving justice involved clients. So where is the last session live? Meaning the date will be Thursday, December 16th from 4 to 5 p.m. on this Zoom link. And Chris, yes, I can make sure that you get the previous recordings. They're on the UCJC's YouTube website. But I can actually pull that link if you just stay on a little bit longer. I can grab that YouTube link before you sign off. Thank you so much for being here. I'm going to keep this line open. We offer an open consultation hour monthly. So I'm just going to stay on this line. If there's any business that you need to attend to before you jump off, I'm here. If you have any questions that came up from the session or feedback, I'm here to talk. So thank you all so much. I know there was a lot of talking at the end of a workday. I hope that you took away something useful for you. Thank you to those of you who shared some great examples. Appreciate it.
It was really good. It was really good.
So the first thing that I'm going to do is just sort of navigate through all of these windows. And once I've done that, I'm going to go find our YouTube page. So just give me 1 moment. And there's a lot on there at this point. I'm going to give you the direct link to the first session. When I have all 3 sessions, I'll turn it into a playlist. So you'll have all 3 wrapped up together. And then, of course, you can go down the rabbit hole. I'd love it if there were other sessions that jumped out at you. Our director, Emily Salisbury, offered a great case planning session that sort of digs into this deeper that I think I hope would benefit and offer some more. So just 1 second. Let me make sure. are. Thanks for your patience. Apologize. You don't want to watch someone finding a YouTube link, but alas. And I just sent it directly to Lincoln. Sorry, Lincoln. Singled you out there. There we go. Everybody there. Okay. Any other questions that I can answer or things you want to talk about? I'm going to actually stop the recording now. Here we go. Stopping that.